Who knew that prostate cancer would become increasingly difficult to treat? I'll date myself. Docetaxel was, at the beginning of my training, was not a treatment option. And now it's becoming increasingly hard. So fortunately, we have Dr. Swami joining us today, medical oncologist at Huntsman Cancer Center at the University of Utah. So Dr. Swami, thank you for joining us.
Good afternoon, everyone. My name is Umang Swami, and I am an assistant professor in oncology at Huntsman Cancer Institute at University of Utah. I would like to thank the organizers for inviting me and for all of you to join the OneOncology Annual Conference 2022 on this weekend. So today I will be discussing updates in management of metastatic prostate cancer. These are my conflicts of interest. So the learning objectives of today's talk are updates in management of metastatic castration-sensitive prostate cancer. I will be talking about triplet therapy and role of biomarkers. I will also be talking about single-agent PARP inhibitors, combination PARP inhibitor trials in mCRPC, and the current updates with lutetium 177 PSMA 617. So this figure kind of summarizes the treatment options for prostate cancer. For high-risk localized disease, we have abiraterone, which was recently shown to improve outcomes in a STAMPEDE trial. Then for non-metastatic CRPC, we have 3 novel hormonal therapies. For metastatic castration-sensitive prostate cancer, again, we have multiple novel hormonal therapies as well as 2 triplet regimens, which have shown to improve survival outcomes. And finally, for castration-resistant prostate cancer, we have taxanes, novel hormonal therapies, radiopharmaceuticals, PARP inhibitors, and some immunotherapies. So this table basically kinds of summarizes all the successful randomized phase 3 trials, including ADT with docetaxel or ADT with novel hormonal therapies, which have shown to improve overall survival. But this was the recent update. Basically, this table shows 2 studies, ARASENS and PEACE-1, in a summarized fashion. ARASENS was a phase 3 trial which enrolled 1,306 patients, which were randomized in 1-to-1 to receive either ADT with docetaxel or ADT with docetaxel with darolutamide. And overall, the outcomes showed that the triplet combination reduced the hazard ratio of death by 32%. Another similar trial, PEACE-1, it enrolled only de novo mCSPC patients. Patients were randomized in 1:1 in like 4 different arms. And on summary, the standard of care treatment of ADT with docetaxel was found to be inferior to ADT with docetaxel with abiraterone. And the improvement in survival with the triplet was around 25%. However, I would like to point out that none of these trials have actually compared whether the triplet combination of novel hormonal therapy with ADT with docetaxel is actually better than the doublet combination of ADT with NHTs. And this trial will soon be conducted, hopefully. Now, changing focus to biomarkers, I would like to first go over the landscape of mutation profile of advanced prostate cancer, because many of the slides and discussion will kind of focus on that. So in our clinics, we routinely send both blood and tumor for mutation testing, and this led to a collaborative effort between us and Foundation Medicine to analyze around 3,400 unique prostate cancer samples. So this histogram shows the frequency and type of genomic alterations in advanced prostate cancer. And the most common alterations which were noticed were in TP53, PTEN, AR, MYC, and BRCA2 genes. This histogram tries to look at what's the difference between the metastatic and the primary sites. It needs to be noted that they were not paired biopsies. However, TP53, PTEN, AR, and MYC seem to be more concentrated in the metastatic sites, and the primary sites were enriched in SPOP mutations. And this histogram shows the proportion of somatic and germline mutations in DNA repair genes. BRCA2, ATM, and CDK12 are very much enriched in terms of these defects in prostate cancer. So to summarize, or to take home messages, that analysis of this cohort showed that approximately 57% of the patients have targetable genomic alterations, and these alterations may provide a roadmap of treatment strategies in metastatic setting. And registration trials evaluating PTEN and homologous recombination repair gene defects in MCSPC setting are currently ongoing. So we just talked about doublet and the triplet therapies, but do we actually have a predictive biomarker to select which patients can be spared chemotherapy? So to answer that question, we looked at SPOP mutation. So SPOP mutation is involved in the ubiquitination and proteasomal degradation, and loss of function in SPOP protein is an early event in prostate tumorigenesis, and these prostate tumors are more addicted to AR signaling. We previously showed that mutant SPOP has been associated with improved survival outcomes in MCSPC, and similar findings have been reported in MCRPC with novel hormonal therapies. So we asked this question that probably since SPOP mutated tumors are addicted to AR signaling, ADT intensification with novel hormonal therapies but not docetaxel will lead to improved survival outcomes in de novo metastatic castration-sensitive prostate cancer. And again, a collaborative effort with Flatiron Foundation Medicine was done, and we looked at a unique cohort of around 417 patients who received, with de novo MCSPC patients who received just ARAT or docetaxel. Sorry, ARAT means novel hormonal therapies. So our results showed that the patients with SPOP mutation who received novel hormonal therapy as compared to wild type showed a more favorable time to castration resistance and overall survival. Time to castration resistance was not reached in SPOP patients as compared to 16.7 months in wild type. And with regards to overall survival, again, it was not reached, but it was 27 months in wild type. However, this difference was not seen with docetaxel, and the treatment interaction was observed between SPOP mutational status and treatment type for both time to castration resistance and overall survival. So if someone asks me what the future will look like 5 years from now in terms of management of castration-sensitive prostate cancer, I would like to say probably it will be driven by genomic profiles and radiological profiles. So if patients have TMB high or high mutational or mismatch repair deficiency, probably immunotherapy will be incorporated into standard of care. If they have SPOP mutations, probably chemo will be skipped. But if they have triple negative prostate cancer or aggressive disease presentation like with liver mets, maybe the triplet will be the answer. If they have HRR mutations, probably we will be using PARP inhibitors. And if their PSMA scans will show the disease has high SUV, probably we will be incorporating the PSMA targeted therapies. So next some of my slides will be dwelling into the PARP inhibitors. So I just thought to briefly have an overview of the mechanism of PARP inhibitors. So PARP is recruited at the sites of DNA breaks, and it leads to the base excision repair. However, if we use PARP inhibitors, the pathway changes to homologous recombination repair pathway. And if the patients have deficiency in the HRR pathway, it leads to synthetic lethality by transitioning of the path of the repair pathway towards non-homologous end-joining pathway. And there are some PARP inhibitors like talazoparib, which can trap PARP at the site of DNA at the replication fork, causing instability and cell death regardless of homologous recombination repair defect. So this led to, due to these underlying mechanisms, the PROFOUND trial was conducted in patients with DNA homologous recombination repair defect. And this was the first phase 3 trial in prostate cancer to be conducted based on biomarker. And this was the trial design. The patients were randomized in 2:1 to olaparib or treatment of physician's choice, which was ABI or ANZA. The patients were supposed to have progressed on one novel hormonal therapy, and they were enrolled into 2 different cohorts of BRCA 1 and 2 and ATM or other 12 selected homologous recombination repair genes. The study was positive with olaparib showing a significantly improved median radiographic progression-free survival of 7.4 months as compared to 3.5 months with alternate NHT in cohort A, with a hazard ratio of 0.34, which was statistically significant. This was the primary endpoint. In the overall cohort also, the median radiographic progression-free survival was improved. With olaparib, it was 5.8 months as compared to 3.5 months with alternate novel hormonal therapy. Recently, the overall survival data was published in cohort A, which included BRCA and ATM mutations. The median duration of OS was 19.1 months as compared to 14.7 months with the novel hormonal therapy, with a hazard ratio of 0.69, a confidence interval of 0.5 to 0.97, and a p-value of 0.02. In the overall population also, the corresponding durations were improved with a median OS of 17.3 months as compared to 14 months with alternate novel hormonal therapy. Rucaparib was another PARP inhibitor which was evaluated in phase 2 TRITON trial. This is the trial design. Patients were enrolled after treatment with a taxane and an NHT. And the primary endpoint was overall response rate. The results showed that based on independent radiological review, the overall response rate was 43% and the PSA response rate was 55%. This led to accelerated approval of rucaparib in patients with BRCA 1 and 2 mutations who have already received a novel hormonal therapy and a docetaxel. Based on success of TRITON 2, TRITON 3, which was a phase 3 study which evaluated rucaparib versus treatment of physician's choice in BRCA and ATM mutations, was launched. Patients who have progressed on NHT and who have not received chemotherapy were enrolled in this study. This was the first study actually to have docetaxel as treatment of physician's choice. Patients were randomized in 2:1, and the primary endpoint was radiographic progression-free survival. And this was the statistical design. The primary endpoint was radiographic progression-free survival in BRCA-mutated patients, and if positive, it was supposed to be evaluated in intent to treat population. In the BRCA subgroup, the rucaparib showed to improve radiographic progression-free survival to 11.2 months as compared to 6.4 months with treatment of physician's choice, which was statistically significant. And similarly, in the intent to treat population, which included the ATM mutation also, the radiographic progression-free survival improved to 10.2 months with rucaparib as compared to 6.4 months with treatment of physician's choice. So this is the current approval status of olaparib and rucaparib. Olaparib is approved after enzalutamide or abiraterone treatment in 14 different mutations, whereas rucaparib has an accelerated approval in patients who have received a novel hormonal therapy and a taxane regime, and its approval is in BRCA mutation only, and these mutations can be either germline or somatic. So, however, current studies are now evaluating PARP inhibitors with NHT in both selected and unselected patients just because of synergy seen in preclinical studies. This slide shows the 4 currently ongoing studies of PARP inhibitors with novel hormonal therapies. Surprisingly, PROPEL was positive, magnitude was negative, and recently, based on a press release, TALAPRO-2 is positive, and the CASPER study is currently ongoing. So PROPEL was the first randomized phase 3 trial which evaluated the efficacy and safety of olaparib plus abiraterone versus placebo plus abiraterone in patients with metastatic castration-resistant prostate cancer. These patients might have received docetaxel in castration-sensitive disease, and the primary endpoint was investigator-assessed radiographic progression-free survival. At the pre-planned interim analysis, the results met its primary endpoint of significant improvement in radiographic progression-free survival with experimental treatment as compared to the control. The median radiographic progression-free survival was 25 months versus 16 months with olaparib as compared to placebo with abiraterone. And the hazard ratio was 0.66, which was statistically significant. The most common side effects were anemia, fatigue, and nausea. Updated biomarker analysis were presented at ESMO, and they again showed that even in non-BRCA mutated patients, the difference in radiographic progression-free survival was statistically significant of 24.1 months versus 19 months. And as I discussed, this was the press release of TALAPRO-2, which showed enzalutamide with or without talazoparib met its primary endpoint. However, the results are still awaited, and probably they will be presented at one of the international meetings. Finally, talking about lutetium, which is a new addition to the treatment landscape of prostate cancer. So lutetium-177 PSMA-617 is a radioligand therapy that delivers beta particle radiation to PSMA-expressing cells and surrounding microenvironment. So this phase 3 VISION trial evaluated in patients with metastatic castration-resistant prostate cancer who have received one novel hormonal therapy or 1 or 2 chemotherapy regimes and had PSMA-positive scan. Patients were randomized in 2:1 to either lutetium with standard of care versus standard of care alone. And these were the results. The addition of lutetium to standard of care therapy improved the median progression-free survival as well as overall survival, leading to its FDA approval. It reduced the hazard ratio of death by 38%. The incidence of adverse events were more with lutetium, but the quality of life was still maintained. The most common adverse events were fatigue, dry mouth, nausea, anemia, and back pain. However, in the VISION trial, the standard of care did not allow cabazitaxel, so there was, I would like to discuss this trial, therapy, which basically randomized patients having positive PSMA scans with more than 10 SUV and negative FDG PET scan, and at least one lesion more than 20 SUV to either cabazitaxel or lutetium. The primary endpoint was PSA response, and the results showed that the lutetium led to a significantly improved, a significantly higher PSA response rate as compared to cabazitaxel. With lutetium, it was 66%, and with cabazitaxel, it was 37%. The grade 3 and 4 events were lesser in lutetium with 33% versus 53% with cabazitaxel. However, the updated overall survival results were not significant. There was 20% crossover, but the median overall survival was 19 months in both arms. Thank you.
So we do actually have time to have a few questions. Next, I'll start one. Next step, radioligand therapy, future directions, additional agents that are in development. Can you teach us a little bit about that?
So I believe Dr. Tagawa will be giving a presentation tomorrow with regards to actinium and other agents. So
we should leave a teaser for tomorrow. That's a good point. Awesome. Teach us what you think about NGS testing and metastatic prostate. When should we do it? Should we repeat it?
So one interesting thing which we learned from the PROFOUND trial was that the 31% patients were not able to be enrolled or were not even eligible for the study because their tumor tissue was old, which couldn't be sequenced. So it's better to sequence these tissues as soon as possible. It's our routine practice to sequence them at initial diagnosis of castration-sensitive disease to avoid that challenge. Again, we do have multiple registration trials in castration-sensitive setting, as well as some biomarker studies which are evaluating these mutations. So it makes sense for us also. But learning from the PROFOUND trial, I will suggest it's better to sequence them earlier than later and waiting for the MCRPC stage.
Do you think both in academia and in the community we're doing appropriate hereditary testing?
I think the hereditary care testing is quite less, both in academia and as well as in community practice. And again, finding these germline mutations can change not only the prognosis, but can also provide some more treatment opportunities with regards to PARP inhibitors, as well as counseling and prognostication and of family relatives. So it should also be emphasized.
Awesome. Vasily.
I know it's early data, but could you comment on some very exciting CAR-T data in prostate cancer?
So there are multiple studies which are trying to look at different CAR-T studies. So far, the results are not that exciting. We also have some CAR-Ts at our centers, but we are not seeing that good of a response which we saw in liquid malignancies.
I mean, the whole concept that we're talking about CAR-T and solid tumors, to me, is exciting. But yeah, we need a lot more understanding of that. Awesome. Any other questions? Dr. Swami, really appreciate you joining us today. Thank you for traveling, and thank you for your talk.